today will definitely I'll definitely take you through anemias. Okay, I hope you guys are reading. Yes, I hope you guys are reading. Precious,
Yes, we are
Yes.
reading.
Yes.
mnasoma?
Eh.
Okay. Okay, so I'll take you through anemias, and just by an introduction, uh, is that I want somebody to give us maybe a brief description of anemia, the general description. What is anemia? I love an interactive class, so that's the reason why I literally have to point someone, Sharon Sambu. Can you give us your definition of anemia? Polycarp, definition of anemia? Okay. Ofula, Jerry, a definition of anemia? Yes, I can see you carrying up your hand. Yes, Ofula.
Anemia is a condition whereby the red blood cells or the amount of hemoglobin in the blood is it's low. Yeah.
Okay. Those your take. Precious, what's your definition of anemia?
A condition in which there is a decreased number of red blood cells.
Okay, also a definition. That's true. Any other trial you're leaving behind? Yes, Jerry. Jerry, I can see you carrying up your hand still. Okay, so literally all those are true, but according to the WHO, we define anemia as the reduction of oxygen carrying capacity of the blood. It is the reduction of oxygen carrying capacity of the blood, either with inadequate oxygen supply to the tissues. And you know that when you have inadequate oxygen supply to the tissues, this will lead to an overall fatigue of the body as a result of necrosis. The moment we don't have enough oxygen, that will mean that we will not have enough physiological activities of the constituents in the body, and thus the overall fatigue. So that one usually leads to anemia. And it is diagnosed usually when there's a reduction of these RBCs, when the number of RBCs are usually below the normal range for both genders. And some of the demographic factors that are usually influenced by these are age and sex of an individual, which also dictates the definition of anemia. But more accurately, this anemia can always be defined as the reduction in red cell mass. Reduction in red cell mass, that one will mean that's reduction in size of this. When the RBCs reduce in size, inadequate oxygen carrying capacity within these individual cells, thus an overall fatigue of this person, thus defined as anemia. So now that you have a skeletal definition of anemia, we have to go straight ahead and classify them. So the classification anemia is broadly categorized into two categories. Number one, it is categorized by etiology, the causative agent, under etiology. So under etiology, we have number one, it can be caused by decreased red cell production. Can be caused by decreased red cell production. Now, just a question. What can cause these circumstances where there is a decreased red cell production leading to anemia by etiology of classification? What are some of the circumstances that we can usually experience the decreased red cell production? Yes. Let me point out Victor Masinde. What circumstances can we experience a decreased red cell production?
I think the damage in the bone marrow.
The damage in the bone marrow. The damage in the bone marrow. I wish, Victor, how I wish you could have been more specific. What damage of the bone marrow? Yes. Nurse Club. Yes, Nurse Club, you can talk. Nurse Club, if I can see you're raising up your hand, you're able to talk.
Okay, I just wanted to say one of the causes that can lead to decreased production of red blood cells. We can talk of things like nutritional deficiency, having a poor diet.
Nutritional deficiency. Very true, very true, very true. That one is very correct. Okay, can somebody maybe add a good point to what Victor echoed earlier? He talked of the damage to the bone marrow. Can somebody be specific? What can literally damage the bone marrow? Yes, Lavina Chin. Lavina Chin. George William. I can see Greg Bellamy. Bellamy, what can literally damage the bone marrow?
We have myeloid metaplasia.
Myeloid metaplasias, okay. Those are important. Patrick Masuga. Patrick. Okay, Nurse Club, can see you're having two accounts. Even more than two accounts. Yes, you can talk. Yes, Nurse Club. Okay. Any other intake that can lead to a reduction in red blood cells? Because I can see that the Nurse Club, I don't know the name though, is that he has mentioned something to do with nutritional deficiency. That is mineral deficiencies, either lack of iron, zinc, and even copper, which are critical in the hematopoietic process. So if these nutritional factors are not sufficient or they are lacking, then definitely we'll have an immature RBCs that are being produced. And when we have an immature RBCs, that will mean that they will not have a capacity that they're needed for to carry the oxygen. Yeah, so you're called very nice. Okay. Another one is vitamin deficiencies, which falls under nutritional deficiencies such as the vitamin B12, which are very essential for the maturations of these cells, folic acids, and even vitamin B plain, that is the pyridoxines. and hormonal deficiencies and protein deficiencies that cannot be left behind. So by etiology, we have said that this anemia can be caused by decreased red cell production. And one of the major factors can be as a result of nutritional deficiencies and even in the damage of the bone marrow. Okay. The second one by etiology is that it can also be classified as hemolytic anemia. That is the destruction of the RBCs. When the RBCs are being destroyed, either through accidents or during mother to child during the HDN, hemolytic disease of the newborn, where the short span life of RBC is usually short-lived. And we have by etiology, it can also be classified as mixed anemia. Mixed anemia. And mixed anemia can also can be categorized under megaloblastic. That means increased in size of these RBCs, usually associated with hemolysis. Then the second classification is by morphology. By morphology. What do you mean by anemia classified under morphological features? What can you say about that when anemia is classified under morphological features? Yes, Levi. Yes. Patrick Masiga is saying according to the structural appearance. That's true. That's very true. Okay. So under morphology, we can classify them broadly into three. Number one, we can classify them under microcytic hypochromic anemia. Morphology is appearance, what you're able to see, the size, the color. Yeah? When you talk of the size, you talk of the size of the cell membrane. You talk of the size of the central pallor. You talk of the color, the chromatic features. And by morphology, the first one is, it can be classified as microcytic hypochromic anemia. Okay, can somebody give us the meaning of that? When they say that the anemia is microcytic and hypochromic in nature, what does it mean? When we say that the anemia is microcytic and hypochromic in nature. Yes, Stella.
They are small and pale in color.
Very good. They are small and pale in color. Small and very pale in color, true. And microcytic hypochromic anemia are usually caused by several factors. Yeah? Number one, they're caused by iron deficiency. When there is insufficient iron, because for the RBCs to mature and also to survive, they need iron component molecule in their HB structural chains. Another one, we can also say that the microcytic hypochromic anemia can be further categorized into 4 sub-anemias. Microcytic hypochromic anemia can be further subclassified into 4 types of anemia. Number one, iron deficiency anemia, where the iron is deficient. The RBC is deficient of the major constituents of the HB, that is the iron. Number two is the thalassemia. Thalassemia is the second most common type of anemia in Kenya, and I think also worldwide, where we'll have thalassemia major and minor, literally, we'll check into that later. Then we have anemia of the chronic disease. Anemia of the chronic disease. Who can give me an example of anemia of the chronic disease? Any disease, a chronic disease that can cause anemia? Any chronic disease that can cause anemia? Patrick Masiga is saying malaria. Malaria, but that one I will say that out of 2 marks, I will give you a half a mark. A half a mark. Yes, malaria is cancer. But can you be specific? Malaria? Yes, can be. I can say Stella. Stella, you are carrying up your hand.
Chronic kidney disease.
Oh, okay. Any other trial? Chronic kidney failure. Okay, that is not more specific. Chronic kidney failure. What can cause kidney failure? You know, kidney failure is not a disease.
Sickle cell anemia.
Sickle cell anemia. That is the type of anemia. That is not a disease in terms of anemia of a chronic disease. Literally, yeah. Acute malaria. That one is very true. Acute malaria. Now you can earn your 2 marks. Yes. Any other trial? Any other trial? Any other trial? Yes, no.
Malignancies.
Yes, where?
Malignancies.
Malignancies. Very true. Malignancies, like, that is broad. There are a lot of diseases, chronic diseases, that can usually cause anemia. Malignancies.
Okay, let's
Wafula is talking of leukemia, chronic infections in TB and HIV. That is fasting. That's true. Yes, where?
okay, malignancies. We can talk about things like leukemia, lymphoma. Yeah,
Yeah, and you can even talk of cancer. Yeah, can even talk
yeah.
of cancers. Liver disease. That's true, but you could be more specific and say maybe liver cirrhosis in terms of liver disease. You can talk of pancreatic cancer. You can talk of prostate cancer. You can talk of esophageal cancer. Yes, where? Yes, I can see you carrying up your hand. Where? Okay. Number 2, by morphology, you can also classify them under normocytic, normochromic anemia. Normocytic, normochromic anemia. What do you mean by that? Normocytic, normochromic anemia. Yes, I can pick up Naomi. Naomi. Yes, Naomi. Naomi. Okay. Literally pick Julie. Julie Masharia. Julie Masharia. Okay. You guys don't want to talk. Only a few people are very active. Yeah. I'll pick Ivan. Ivan Michael. Ivan Michael. What do you mean by normocytic, normochromic anemia?
They have the normal color and the normal type.
They are?
Normal color and normal type.
We are not able to hear you. We are struggling to get you. Yes?
I'm saying they have the normal color and the normal size.
Normal size and normal color. Just as it has been typed by several participants here, the likes of Masiga. Okay, and Wafula, nice. So, normocytic, normochromic anemias can also be divided further into types of anemias. Number 1, anemia of chronic diseases, as mentioned earlier. Number 2 is acute post-hemorrhagic anemia. Then number 3 is hemolytic anemia, aplastic anemias, and lastly, myelophasic anemias. So literally send you the notes and you will read on each and every sub-classification. What I want you to do is that don't overread the sub-classification types. Just understand their meaning. If I say hemolytic anemia, what do you mean by that? Yeah. So the major thing is you have to understand the classification of these anemias based on morphology and literally etiology. Okay. Under morphology, lastly, we have macrocytic normochromic anemia. The first one we had microcytic hypochromic. Second one was normocytic normochromic. Then lastly, by morphology is macrocytic normochromic anemias. What do you mean by that? Yes, I'll pick Otieno. Yes,
The red blood cells are larger than normal.
the larger than normal. Okay, Jerry.
Macro mean symbolizes large, so I can say yeah, it's larger than normal.
Larger than normal. They don't. They surpass the normal size, the normal range size of the RBCs. That's very true. And normochromic anemia. What do you mean by normochromic? Normal in color. Yeah, normal in color. So under microcytic, we can have megaloblastic anemia. In fact, that is one of the major examples of macrocytic anemias. Megaloblastic. Megaloblastic anemia is a very special type of macrocytic anemia that is usually caused by the deficiencies of vitamin B12 and folic acids. The second one we have is marked reticulocytosis. Marked reticulocytosis. Marked reticulocytosis, sorry, the retics are high in number. Marked means they're high in number in the peripheral blood film, in the periphery of the blood. So they are under macrocytic normochromic anemias. But now a very special question comes here. Why do you think that marked reticulocytosis is classified under macrocytic normochromic anemia? Who can give me the physiological aspect based on hematopoietic knowledge that we learned last? Yes. Why do you think they fall under macrocytic normochromic? Marked reticulocytosis. You know, retics are immature RBCs. And when you check into the normal adults, when you check into the normal adults in the peripheral blood film, there's a certain number that the retics should fall. In fact, they should be even very few in adults as compared to infants, because for infants you find that the hematopoietic process is still going on. Yeah? So there's a certain range. In fact, now retics, infants have quite more retics in their peripheral blood film as compared to adults. But when you are an adult, we presume that now the RBCs that are being released into circulation should be mature enough and should be within the normal range. But a scenario where you find marked retics in an adult blood film, it should give you an alarm ya kwamba this thing is anemia. And it is not any kind of anemia, but this one is a macrocytic type of anemia. So what is the physiological context behind it? Yes, this is just knowledge of physiology and hematology, the first topic, hematopoiesis. Who can have a try? Yes, Victor.
Reticulocytes are immature red blood cells, and their physiology, they are usually larger than red blood cells. So I think that's why they are classified under macrocytic anemia.
Okay. Okay. That's from Victor. Yes, Baraza.
So reticulocytes, reticulocytes, which are also called the polychromatophilic erythrocytes, are immature red blood cells which each actually have a reticulum, and they they are actually located in the blood capillary. So when they stage actually mature to become to gain that by concavity, it may lead to anemia. Actually, that's in the molecular red blood cell. Yeah.
Okay, that's from Baraza. Any other take? Why do you emphasize that it is macrocytic? In fact, they're marked. Whenever you see marked retics, if you're writing a diagnostic, you're writing a diagnostic report, then marked reticulocytes in, and even count them using reticulocyte and counting methods. We have methods how to you count retics against the mature disease, then you multiply usually them by 1,000. Yeah. So what can you say under the physiological context? That one you guys go and check. In fact, I don't know. I'll be tempted to bring that one also in section B. When you see marked retics in the peripheral blood film of a 38-year-old, or maybe on a 30-year-old, or a 40, or a 27, what does it mean? Give the physiological context of it in relation to the morphology classification. Then the next one is what we call the pathophysiology of this anemia. So we have said anemia is broadly categorized into two, and within those two main subclassification, they are further subclassified into distinctive examples of anemia. So the second aspect of this discussion is the pathophysiology of anemia. And under the pathophysiology of anemia is that, okay, what do we mean by pathophysiology? Because now we can literally talk and maybe somebody doesn't get to understand the meaning. What do you mean by pathophysiology? A pathophysiology of anemia. What does it mean? Lavender, Precious, she's very quiet. Najua wewe ni kiongozi lazima changamke. Yes. Precious, your mic is on.
Okay. Pathophysiology is the functional change that occurs, of a disease that occurs.
A functional change that occurs. Okay. Any other take? You know, there are two words there with different meaning: patho and physiology. You guys did physiology, but you didn't do. Did you do any pathophysiology aspects in physiology? I don't want you guys to, I don't want to give you a hint on the meaning, but did you guys do any patho in the physiology you guys were doing last semester? Yes?
No.
Okay. Okay, now what is pathophysiology then? I don't know. It's only Precious and Stella. Ladies are not nini. Hamtaki kuchangia? Let me point out. Wekesa, what is pathophysiology from your own understanding? Wekesa Sikuta. Yeah? Sharon? Yes, Belvin. Yeah, nice.
Pathophysiology is the study of normal physiological process altered by a disease or an injury.
Pathophysiology is the study of
normal physiological process altered by a disease or an injury.
Very true. Altered by a disease or an injury. The study of just how the body definitely functions normally, and now the disease or the activity that alters the normal functions of this body. Pathophysiology. Very nice one. So that is what we want to check into. Now the pathophysiology of anemia. Yeah? In the process of hematopoiesis. In the process of hematopoiesis, where the primary progenitors usually divide into myeloid, lymphoid. We have the hematopoietic stem cells within the bone marrow, HMPSC. that is the parent progenitor cells. Then they divide further into secondary progenitors, the myeloid and the lymphoid, which will now give rise to different subsections of these cells. The RBCs, in their categories as the lymphocytes, then we'll have the white blood cells of the lymphoid nature, and also the platelets, megakaryocytes. Now, in that process, that is the physiology of blood within the process of blood formation. So, in this context, we usually understand that hematopoiesis is just the normal process that usually takes place in the body. Wherever you are sitting, wherever you are, when you are sleeping, kama unatembea, that process usually occurs. So that's the reason why it's called physiology of blood. The physiology of blood formation. It is a normal process. But now when we have conditions that are setting in that usually tamper with this physiological aspect, now that is now what we call the pathophysiology, irrespective of the stages. So I hope you guys have understood that in context to anemia. Yeah, in context to anemia and blood formation. So number one of the causes of pathophysiology, we can talk of tissue hypoxia. Tissue hypoxia. And tissue hypoxia is just reduction of oxygen, insufficient oxygen. Tissues are not getting enough oxygen. Okay, what do you think will happen if the RBCs, because the RBCs usually, it is the main function of the RBCs to actually transport oxygen and pick CO2 to avoid toxicity. But take a scenario whereby the anemia or that anemic characteristic, the RBCs is either small as compared to its normal range, or it is macrocytic in the sense that now it is an abnormal feature of that cell that are not able now to pack the sufficient oxygen. So that will mean that if oxygen is supposed to be transported to the lungs, or if oxygen is supposed to be transported to the brain, or if oxygen is supposed to be transported to the distant parts of the legs, that is the iliac or the iliac veins, then definitely will mean that there will be no sufficient oxygen to able to help these organs to carry out their normal physiological functions in terms of metabolisms and what have you. So that is what now we call hypoxia. So that will mean the lungs will have hypoxic features. It will be hypoxic in nature. It will lack sufficient oxygen. Why? Because either we have RBCs that are there, yes, but now they are small. Their oxygen carrying capacity has been diminished. So that is the first example of pathophysiology called tissue hypoxia. So this one is usually as a result of impaired functions. It results into the impaired functions of the tissues, and the degree of impairment of these tissues usually depends on oxygen carrying capacity, either to the cardiovascular system or either to the CNS or even to the skeletal muscles. Yeah. You guys will do something in pathology called necrosis, and one of the major causes of necrosis is tissue hypoxia. Very critical. Number two, pathophysiology, you can say that we have compensatory mechanism. Compensatory mechanism, where now you will talk about what we call the increased plasma volume. Increased plasma volume. Okay, what do you mean by increased plasma volume? Increased plasma volume. Or number one, what do we mean by compensatory mechanisms? What do you mean by compensatory mechanisms? Number one, the pathophysiology is that if you see a tissue hypoxia, hypoxic in nature, how would you notice that this guy is hypoxic? How would you notice that? As a nurse, you are doing ward rounds and you realize that a 12-year-old child or a 10-year-old child. Yes, Masinde, how will you literally notice that?
Through cyanosis.
Through cyanosis, very true, very scientific. Cyanosis, bluish, of either the fingertips or the palms, number two. How will you notice that this child is hypoxic in nature? Let me take, okay, Lavin Achieng. How would you notice that this infant is hypoxic in nature? Yes? Any other trial? Yes,
Increased respiratory.
Belvin? Mercy Joy? Or, okay, Belvin, you want to talk? Okay.
Tachycardia.
Yes.
The infant is breathing fast.
We are not able to get you. I don't know where you are. You're so low. Masinda has given us a very clinical answer. In cyanosis, when the child is cyanotic in nature, you check the bluish, colors on the palms there or the tips. You also check on the eyelids. Sindio? Yeah, check on the eyelids. Yeah, Belvin has type trachopenias. That's true. Check also on the eyelids, definitely. Check on how they are behaving. Akitoka kwa bed pale kwa ward round, ameenda kujisaidia maybe in a washroom. Check how they are walking. The fatigue nature will tell you now there is insufficient oxygen. Check the breathing, how they breathe. That is the reason why you guys have stethoscopes. And in stethoscopes now it will bring you now to what you call the compensatory mechanisms. If they are breathing rapidly, that will mean that definitely now there is insufficient oxygen carrying capacity, so the body resorts to other mechanisms where now they are able to supply insufficient oxygen to critical tissues. So when you see tachypenias and tachycardias, literally they are breathing faster, literally. So that is one of the major critical compensatory mechanisms in anemia. So number two is compensatory mechanism, where you will check an increased oxygen delivery from HV to the tissues. When you find out that now there's oxygen carrying capacity is high in some other tissues as compared to other tissues, especially in the liver, you literally now notice that, okay, this one is a compensatory mechanism that gives you a leeway that this person is suffering from a chronic anemia. Number two, you can talk of increased erythropoietin production. You notice that there is increased EPO. The hormone is very elevated. How can you diagnose this? Because that one you cannot see by your naked eyes. How will you notice that there is increased EPO? Yes? It needs a critical thinking, just a very small critical thinking, and then you have the answer. How would you diagnose that? How would you literally diagnose EPO, marked EPO? Marked EPO. How would you diagnose that? Yes? Yes, Masiga, it is erythropoietin hormone levels, but how would you diagnose that? Okay, in simple terms, how would you know that erythropoietin is marked is being produced highly more than normal, because that is one of the major compensatory mechanisms that the body usually resorts to. You know, EPO is usually produced when a signal is sent to the bone marrow. The signal is sent to the bone marrow that ya kwamba, because EPO, once an EPO has been produced in the blood, signal is being sent directly to the BM, the bone marrow. We need more RBCs. Can you stop now producing lymphocytes and WBCs? Can you now stop producing platelets? This person is seriously suffering from anemias of the RBCs. We need more RBCs. And now the bone marrow will be overwhelmed and it will overwork because there's high production of erythropoietin. It will stop all productions of the WBCs and platelets up to a certain level. In fact, they'll be small, or they'll be low in number as compared to the RBCs. So the bone marrow will be overwhelmed, and that is now where you find now imekuwa overwhelmed, inafanya kazi hapa next, and now it is producing immature RBCs. So you will find the reticulocytes highly marked in the peripheral field of that individual. When you take the blood, you smear it in a microscope slide and you view it, you'll find that there is high numbers of retics. That will literally tell you that, oh, EPO was being overproduced and it was overwhelming the bone marrow, so they had no any alternative but produce immature RBCs, that is the retics. That is one feature you can literally use to identify that EPO has been produced. Number two, you can go for further diagnosis, because that one we have used microscopic in nature, microscopic tool. You can also do flow cytometry, where you take the blood and the EPO, being that it is an hormone, and hormone is protein in nature, you literally find there's an expression of these proteins in the blood. High expression of these proteins either in the bone marrow or in the peripheral blood field or in the liver will literally tell you that, okay, this person is suffering from anemia, and therefore the EPO is usually produced as a compensatory mechanism to carve out these members. Yeah? Are we getting it clearly now? Yes? Okay. The next one is another aspect of compensatory mechanism is usually increased plasma volume. When the plasma volume is increased. Why do you think we need to increase plasma volume? Increased plasma volume. What do you mean by that? Increased plasma volume. Yes, Selena. Yes, Abby Selena.
Okay, I think
Is it Abigail or Abby?
Abigail.
You are Abigail.
No.
Eh? No, that's not
No.
Abigail, because Abigail should be somewhere close to female. Yeah, if I'm not wrong, yeah. So
I guess
yes,
it's the part of the blood, liquid part of the blood.
yes, it should be the user contributing to the answer, because the account is for Abby. Yeah, but okay, is the Selena? You have said what?
The increased liquid part of the blood.
The increased liquid part of the blood. Very true. Yes. Now the gentleman next to Abby, because I think maybe you guys are having discussion. So yes, the gentleman.
Yes.
Yes, can you now unaweza changia sasa, saidia Abby Selina now.
So I was saying maybe the same thing, that increased plasma volume is just the increased liquid part of blood. We always know that plasma is part of blood and it is always 55%. So if it is increased above that, then that's what we mean by increased plasma volume.
That's true. That's true. The increased liquid part of blood. Okay, why do you think this one is very critical? The gentleman, yeah? I don't know your name. What's your name? The friend to Abby.
I'm Newton.
You are Newton. Newton, today you are at Abby's place.
You are getting too personal.
It's okay, it's okay, it's okay, it's okay. Yeah, literally, I know exams in a Caribbean, so definitely you guys have to study and what have you. So, Newton, what do you think?
Pardon?
What do you think? Why do you think plasma volume should literally increase as a compensatory mechanism? What is the context behind it? Jerry is saying to maintain the blood pressure. Okay, it's to maintain the blood pressure. Yes. Joshua is saying hypovolemia, but now that answer is hanging. Joshua, it's a good one, but it's hanging. Yeah. Boniface is saying to improve oxygen delivery. Lavender is saying to reduce blood viscosity. That's true. Yeah, so you guys have answers. Yeah? It's only that you guys don't want to talk. So I literally want you guys to be out uh, spoken and monge because you guys are medics. So it will be so beautiful when you verbally and confidently, I mean, explaining your answer. Yeah? So it's cute that way. Yeah? Literally. So all of you have a good answer. Belvin is giving us to maintain the BP in circulation because when this oxygen is being delivered through the RBCs, then definitely will mean that now there must be also the speed of delivery must ensure that there's a speed in delivery. So that means that we must have an increased blood mass volume to ensure that the RBCs are being taken to the right Okay, sorry for the network. Sorry for the network. Sorry for the network. Okay, how would you notice that, Lavender?
Pardon?
How would you notice? How would you notice that there is actually increased plasma volume in a 12-whole-year infant?
It will cause edema because plasma is the fluid part of blood, so swelling will occur.
No more additives. That's very true. That's very true. That's very perfect, precious. Yeah, cause of edema. You can check on the limbs. You can check on the back of the palms, and literally, and you find there's edema. You can even check on the veins, the junctional veins. You find the swollen parts. Okay. Now, the third part of physiology, yeah, also high blood pressure. That's true, Clinton. The third part of pathophysiology of anemia is usually the rate of blood loss, where there is usually the rapid rate of blood loss, and there is more severe symptoms that usually occurs, especially in elderly due to this. Yeah. While the slowly falling HB allows for hemodynamic compensations, usually seated with less symptoms. So there's rate of blood loss. And the fourth one is factors which are related to specific cause of the disease, as we had mentioned earlier. Okay, so I've given you four pathophysiological factors of anemia. Given you tissue hypoxia, compensatory mechanism, rate of blood loss, factors related to a specific cause, and you can list them as many as you want. The next part of this discussion, I'll take it to the symptoms of anemia. Symptoms of anemia. So you can divide these symptoms under neurological symptoms, the symptoms affecting the cardiovascular systems, the symptoms affecting the musculoskeletal, the symptoms affecting the GIT and the genital tracts. Also, for example, the symptoms affecting neurological symptoms will have dizziness, fainting, and lack of concentration. And by now, you guys are able now to explain what is the context behind dizziness in an individual when they're suffering from anemia. Number two is blood and diminished vision. Number three is headache. The next one is insomnia, lack of sleep. Yeah? Under the cardiovascular, you'll find that we have angina pectoris, dyspnea, palpitations, and intermittent exertions within the cardiovascular. The same to the genital. The genital, we have menstrual abnormalities like amenorrhea and loss of libido and impotence. Okay, why do you think that there will be loss of libido and impotence under the genital symptoms? That's very critical. Why do you think that the individual having more chronic type of anemia usually have low libido and they usually tend to turn out to be impotence actually? Any trial? Any trial? That's a very, it needs just a very critical thinking. Kidogo tu. Poor blood flow impacting sexual response. Sharon, that's very true. That's in fact very true. But I wish you were able to talk verbally and explain it. You know, that is just a sentence. Yes, Newton. Yes, Newton, I can see your hand up.
Okay, I just wanted to add that hypoxia leads to low energy, so therefore reduced sexual desire.
Very true, very true, very true, very true, very true. That's splendid. Another take. Another take. Boniface Okello. Okay, I can see typing the same to what Newton had said. Yes, Hezron. Harrison well.
Okay, I wanted to say that the stress of acute anemia can interfere with hypothalamic pituitary gonadal axis regulation. So this can lead to temporary reduction in testosterone or estrogen hormone, which are both essential or critical for libido.
I don't think sijui kama ni mimi peke yangu ndio nakupata kwa umbali. I'm having difficulties in getting you clearly. I don't know if it is me or the rest of the class. Harrison,
okay,
can you come up just to be clear? Yeah,
am I audible now?
mko wengi. I think ni kama hawasikii vizuri. Yes?
Am I audible now?
Okay, can you try? Can you try? Yeah? Okay.
It's okay. So I was saying that the stress of acute anemia can interfere with hypothalamic pituitary gonadal regulation. So this can lead to temporary reduction in testosterone or estrogen in women, which are both critical for.
I've seen talking about gonadotropins, and definitely that one will dictate maybe the secondary features and blah blah. But I wish now you could become very more clear because you're also okay. That's true. It's physiologically true. Newton had said something very interesting. Yes, Newton. Seeing carrying up your hand. Can see you're losing better.
Yes.
Okay. Yes, Newton. Stop.
May you pardon?
Yeah, you can speak up.
Are you requesting me to say what to repeat my point, or I'm not getting you clearly?
You have said something here in your text that definitely lead to
Okay,
erectile dysfunction.
I've just written that anemia interferes with blood flow, thus causing erectile dysfunction.
Okay. Okay, that's true. Sharon is saying of physiological factors. Okay, but now be more specific, like Harrison and even Newton. Newton had said that definitely lead to dysfunctional erectile. I mean, it will lead to erectile dysfunction because now we have insufficient oxygen supply. Oxygen supply usually carries. Is usually initiated by blood, and when blood is not there, remember that this one is can be as a result of a compensatory mechanism. We don't need much more blood now going now to the penis, yeah, for purpose of erections. But we literally need this more blood now for purposes of anemia. So you literally find that now there is erectile dysfunctions. You can literally explain it within that aspect. Okay, number two, what do you think can lead to impotence? That was as a result of libido. What do you think can lead to impotence? Impotence is whereby, number one, you are able to release the spermatozoas, but they are not able now to fuse and give now the normal zygote form and what have we. Impotence does not literally mean that you are not able to produce the spermatozoa. You are able to produce the spermatozoas, actually. But literally now they are dysfunctional. Yes, where?
Okay, so anemia can lead. Have you said impotence?
Yes, Harrison.
Yeah, I'm saying that anemia. It means reduced hemoglobin. So the fact that red blood cells are reduced, which limits the oxygen transport, the penile tissues, so the tissues of the penis, they require good blood supply so that they can erect. So the fact that oxygen and blood delivery to the penile tissues is low, that means that erection will be somehow.
Okay, where you're explaining the the libido part, and that one we have had. But Kimtai have mentioned something very beautiful there in your text that the nutrients are being interfered with. How I wish he could expound on that because that is where the answer lies. Yeah? I want you guys to go and check on that. The nutritional requirement that you are able now to have for us now to have a mature sperm. Because sperms also they need energy, they need nutrients, they need minerals, they need both inorganic and organic nutrients. That's the reason why mothers are usually advised when the infants are around 6 weeks, kama ile wako kwa weaning stage, wanakuwa advised give them green bananas. Go and have a reason why they're supposed to be advised to have green bananas. Wanaambiwa pea mtoto omena mbichi, just boil and definitely give them and eat. They are advised you are supposed to be taking fresh fish from the lake, literally, the not fried one, very fresh, ile imetoka kwa maji, give them hivyo. So there's reasons behind that. So the nutritional factors of those literally are usually helpful in the developmental of penile, and therefore it is under a secondary influence of high maturations of spermatozoas. This is usually very important. I can see Masinde Victor carrying up his hand. Yes, Victor.
So my take was I thought the sperm has that part of mitochondria. So as we know, mitochondria is for energy production. So when we have less oxygen, So the mitochondria won't produce that energy sufficient for the sperm to swim. I think that's my take.
Okay, Masinde, that's true. But now, you see, mitochondria, that is energy. You know, for impotence, you can have high energy. Si watu wako na impotence hawana nguvu, wako na nguvu. Yeah, they have high energy. Not that they're not releasing the sperms, they release the sperms actually. But now what is the problem with the sperm? So that is lying where Kim Tai said that the nutrients has been interfered with. So that is where the answer of impotence usually lies. Because of course they literally produce. Yeah? So that's the reason why you find that there's an abnormality. A sperm having 2 tails or 3 tails, 2 heads or 4 heads, no tail, a neck and a head, you see? So you can literally link it to that. Yes, lastly, Newton, then you proceed.
Okay, my question, I'm just concerned about this and this impotence and libido. What is the main difference?
Yes, what is the main you know, Newton, I will not able to answer that in a class of 56. So maybe they will give you an answer because for me, I'll literally give you my take, but it will be good when it comes from your colleagues. So maybe you can ask them after the session because I'm very sure when we end up the session, we literally able to answer your question. Yes, Harrison, very kindly keep that to yourself. We will come back to you. Don't worry. Just keep that question. We will come back to you. Don't worry. So we have Newton and Harrison having questions. So we'll answer them at the end of this session. Yeah, and Harrison. Okay. Okay. So those were the major. Can say those are the major symptoms. Yeah. And we also even have signs. So I'll send you a note on the signs of this. So they're just repetitions and there are things that you're able to understand. But the major thing is that I want you guys, when I send you these notes, I want you guys to go and read on now specific types of anemias. The microcytic anemia. What do you mean when we say microcytic anemia? I have a document here that has shortened them, and within 2 days, 3 days, you'll mtakuwa mmemaliza the document. They're very summarized, very direct to the point. There is no extensive reading and what have we. You can also read and understand. And the best way of now reading this is actually form groups, a group of 2 or 3. I can see Selena, they're having a group discussions with Newton. Literally, you can also use that group discussion to discuss on this one. Literally, yeah. Yeah, nice. Okay. Having known that, maybe now we can discuss on the treatment of anemia. Treatment of anemia. And treatment of anemia is, before we go to the treatment of anemia, we have what we call the investigations of anemia. How can you clinically investigate anemias? How can you clinically investigate anemia? Number one, you can use complete blood count. Ile unachukua damu through phlebotomy, either through vein puncture or through arterial puncture. You draw the blood, then you make smears. Just a minute. Okay, I'm back. Are you guys able to hear me? Okay, nice. So I'm saying that we literally first check on the complete blood count, where we check on the red blood cells. You check on the features, the morphological features of the size. You check on the color under the microscope using a well-stained, either using what you call the James stains. You check the red cells, either they are microcytic, either they hypochromic in nature. You check on the distribution of the red blood cell width. Another thing, you check on the bone marrow. The bone marrow, when there is an absence of a certain feature, very special one called iron stone in the bone marrow, indicative of anemias. You check also on the hyperplasias of the bone marrow. So you take the trephine biopsies in the bone marrow, you smear it, and you check on those, the hormones, you check on the stromal cells, you check on the what you call the peroxidases, that definitely tell you. Investigations such as stool analysis, where maybe this person is suffering from amekuwa diagnosed na hookworms. Unajua hookworms are usually considered as parasites which are literally they usually cause intense anemia because they eat blood. Actually, they feed on you, they feed on blood components, and literally they destroy the tissues when they're invading their in their process of actually pertaining their pathology. So the destruction of these tissues literally usually leads to internal bleeding, thus overall anemia. And you will find that maybe there's blood in stools. Definitely will have a conclusive report. You can check also on the GI, the gastrointestinal, and you can use endoscopies where you will take fluids. Maybe you find hemorrhages within the imaging features. Yeah. Okay, just a minute. Okay, nice. Okay, short distractions, but it's okay. So I'll send you the notes on that investigations of the anemia. A very simple one that you can literally read and understand. But the most critical part is treatment. So I want to end this class by talking about the overall treatment of anemias. Overall treatment of anemia. And now by this, I will want everyone to talk. I will want everyone to talk now. Maybe to start with Clinton. Clinton Omboga, can you give us the first treatment nature of this anemia?
Okay, so in the treatment of anemia, we can take in these ions, eat food rich in ions like calcium, iron. I mean, yeah.
Okay. So you have said yours is under nutritional management. Okay, that's okay.
Yes.
Say fruits. Number one, mtu akiwa na anemia unamwambia aende pale market anunue matunda. Okay, that's nice.
Green vegetables.
Okay. Yes, any other take from Kobe? No, not Kobe, but now I will want Lavin. Lavin, can you talk? Levin? Okay. Judith Masika? Okay. Sikuta? Valerie is saying giving oral iron supplements. Okay, that's true. Yes. Lavender? Precious?
Giving vitamin B12 supplements.
Giving vitamin B12 supplements. Okay. Okay. Newton. Boniface is saying bone marrow transplant. That's true. Newton.
Blood transfusion.
Blood transfusion. Very true. I saw some messages also. Somebody was talking about blood transfusion. That's true. Sharon had mentioned blood transfusion. That's true. Okay. Any other intake? Valerie Osoa or Hasoa. Valerie Hasoa. You have a South African name. Are you from Zulu? Masiga is saying folate rich foods. That lifestyle that is very general, very general, but also okay. So you can give iron supplements. What Pressure have said, iron supplements. You can also give what you call the parenteral ions, either injections or orally taken or through nutritional services. Belvin is saying for sickle cell anemia, use hydroxyurea, that is pharmacological management, use of drugs. Yes, Bonface, we have just mentioned that. And also transfusion, that you can give packed red blood cells to this individual. But the major one is that correct the underlying cause if possible. If it is pancreatic cancer, if it is of esophageal cancer, first correct that underlying cause. When you correct the underlying cause, definitely you'll have curbed the entire pathophysiological system of the anemia. So I want you guys to go and read in between and synthesize everything. When you're reading, you make short notes. When you're reading, you make short notes, so that you're able now to understand more. Literally. So you can, there are a lot of investigations. I'll send you this material. There are a lot of investigations you can do under anemia. You can do CBC, you can do bone marrow, you can do estimations of the serum levels, you can do the biochemistry tests, you will even do immunology tests, and many other investigations that now will require even gastric biopsies, use of augmented histamines, and you guys will be good to go. So any question that I can bring in anemia is that broadly classify anemia. That will be very easy. If I say broadly classify anemia and give maybe 5 clinical investigations that are being used. So when you classify anemia under morphology, you will give me 3 examples of anemias under morphology and give me maybe 3 features of these subanemias. When you classify them under etiology, give me 3 classifications of etiology of anemia under this etiology, and maybe you give the features. Then you finish with now the clinical investigation. That one you'll have under your 20 marks. As simple as that. So I don't want you guys to complicate anything. Just go and read with sober minds, and you will pass hematology. As long as you are attending the sessions and you're reading those, there's nothing that will come out of whatever I've sent you. So literally, if you read between, then definitely you get everything okay. Okay, before we wind up this class, maybe we can give Newton and then Harrison Were, because they had pending questions. So Newton, what was your take?
Okay, I had a question, but at least someone next to me has clarified to me.
Nice, very true, very true. Also, you also have somebody like Newton.
Yes.
Yeah, it's true to have a friend. It's true to
Yeah.
have a friend so that you guys can able to discuss. That's true. Yes, Harrison, wewe kupata mtu wa kudiscuss naye.
Okay, so mine was to answer Newton, and I've actually answered him behind the scene here.
Okay. Oh, you are behind the scene. Okay, that's okay. That's okay. Any queries? Any take? Any concern?
About the cat.
Yes.
When are we going to do our cut?
Okay. We are in leo tuko 18th. I think you guys are starting exams in July, isn't it?
Yeah, 1st July.
Yeah, 1st July. So, Precious, can you organize with your class? Because I might say next week, but wengine wako ready. Can you just organize with your class so that we move quick? As early as next week, I can come so that we organize for a cut. So hiyo mtanipea mta discussion kwa group and then mtaniambia. There's no problem. But make sure that
Tulisha discuss week iko sawa.
next week iko sawa. Okay, so we can have our cut next week.
Yeah.
Such a time like this or on Monday?
On Wednesday.
On Wednesday.
Yeah.
Okay, then I will travel there on Wednesday, then we'll have our sitting cut.
Na hiyo cut inakaaje? Clarify.
Hiyo cut ni karatasi tu, unakuja tu na paper tu, paper na kalamu. Where?
MCQs, short answer questions, or long answer questions.
It's a mixed one. We'll have a cut for 3 hours. So it's a very simple one. Newton, naona unashangaa. Don't worry, everything will be fine. Everything will be fine.
Alafu main exam ni 6 hours.
Main exam, ukipita cut, huwezi fail main exams. All of you guys will definitely pass. But just read. If you read, you'll pass. If you read, you'll pass. Yeah. It's okay. So just allow me to end up this class from there, and may you guys have a lovely day ahead. Yeah? Thank you for hosting me, Lavender. Thank you.
You're welcome.
Yeah.